morning as well. Know it's a very busy time of year, and I was joking with a few folks earlier. A little bit of competing interests on TV this morning, so I really appreciate you taking time out of your day to attend. Really looking forward to sharing this article and some of the rationale behind it. But most importantly for me, I'm really looking forward to the discussion afterwards, hearing your thoughts, perspectives as well, and perhaps even future ideas for research among this type. So I'm just going to jump right into it. So just as a quick introduction, whoops, I'm just going to go back. My apologies. About 8 years ago, I moved back to Alberta with my wife. We have 2 young kids. We live here in Northwest Calgary. I currently work as a lead with the Health System Analytics team at the Health Quality Council of Alberta. So that's my day job. And I also work I'm also a senior research associate with the patient engagement platform. So that's how I got to know many of you on the call today and many collaborators as well. So this work, as Sumit mentioned, stemmed from my doctoral research, my PhD, which I recently completed. So I'm thrilled to have that under my belt. And so I'm really looking forward to sharing some of the work that I've done as from that program of research. So the article, as Sumit mentioned, to be discussed will be the lack of patient involvement in care decisions and not receiving written discharge instructions are associated with unplanned readmissions up to 1 year. The link right there is for download. I know Sumit included that in today's invite as well. And as he mentioned, this article appeared back in 2017 in the Patient Experience Journal, which, if you're not familiar, is one of the 2 journals that really focus upon the experience of patients within healthcare systems, their family members, etc. And it's also an open access journal as well, which really it's an attractive journal for myself because, outside of the confines of academia, everyone has a level playing field. They can easily access the paper, see what's going on, and learn more a little bit about it. So when we chose to publish this is an excellent venue from our standpoint. So I'm just going to start off with a few foundational concepts. Of course, recognizing many of you on the call, this will be very familiar to all of you, but I think it's really, really important to set that foundation for the rationale for this type of project as well. So on the left side of this slide, we see just a little snapshot from an article that appeared in the Journal of the American Medical Association, written by Avidas Donabedian, huge public health guru and quality of care guru, and that appeared way back in 1988. So in the article, he talks about measuring quote unquote performance of healthcare providers. And there were 2 main components to that. I mean, technical is very straightforward, as you can expect. If you're going in for a hip or knee replacement, delivering a baby, you expect that the provider providing the care, or the providers, I should say, the teams providing the care, are up to date on their training, current standards, current research, evidence-based practices, surgical techniques, all that good stuff, right? Whereas interpersonal, that's a little bit more of a gray area. It's not even around the technical aspects of healthcare, but there's really an art to it. There's a humanistic component around providing quality care. It's not just in, the art of delivering the care, but in how to do it. There are people who are really, really well versed in delivering both good and bad news to patients, having conversations with patients and their families, determining, what treatments and what regimens are really good for them. So, and coming to that mutual decision as opposed to more of a top-down approach. Of course, this touches upon patient-centered care, and you can see a couple of snapshots from Alberta Health Services, as well as the BC Patient Safety and Quality Council, where they simply ask patients and family members what matters to them. And the definition of patient-centered care from 2001 from the Institute of Medicine, you can see right there, it's providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So once again, just as I mentioned around Donabedian's article, we're stepping away from that top-down approach, that paternalistic view of healthcare, where it's really about shared decision-making. It's really about, having a team-based approach with the center being, the patient, as the name implies, of course. Here's a really nice figure depicting that. This appeared back in the New England Journal of Medicine Catalyst in 2017. And you can see some of the main features that they're highlighted as part of patient-centered care. The big one at the top is the mission and values of healthcare organizations and providers are aligned with patient goals. And you can see other things around transparency and delivery of information, collaborative coordinated care, comfort and well-being are top priorities, etc. So you can see right there. One that's really relevant, of course, to this article is in that bottom left corner. Patients and families are always included in care decisions. So we'll get into that a little bit more as we discuss the article, of course. So the foundation for this research is around the triple aim, which is the Institute of Healthcare Improvement's guiding light, I would argue, for many high-performing healthcare systems. So this stemmed from an article back in 2008 by Don Berwick, who led the IHI for a large period of time, and it appeared in Health Affairs. And basically what he and the authors said was that if healthcare systems capitalize on three main aims, being outcomes, cost, and patient experience, then you are really hitting the mark as a healthcare organization. So basically, if you're seeking to improve patient outcomes, decrease per capita costs while increasing the patient experience, you're really hitting the mark, and you're a top performing healthcare system. So of course, many healthcare systems have adopted this as their guiding light, as I mentioned, in recent years. Many of you are familiar with triple aim concept, of course, and its expansion into now the quadruple aim, which includes that fourth aim of improving staff experience, recognizing how crucial it is to have a engaged, positive atmosphere for your workforce. So I've told this story a few times at a few conferences. So if you have heard it, I apologize. So please bear with me. But it really illustrates my point around sometimes performance measures from an organizational standpoint don't always line up with those of customers in the case of this example, or in the case of healthcare, patients. So this is actually a snapshot from my local McDonald's, actually. I'm not trying to plug business for them. They're doing quite well, but I happened to find myself there one evening a few years ago with my wife and my kids in the rush between the office and the soccer field. You know, we stopped off for a quick bite to eat. And these two screens actually appear if you do look carefully next time you happen to go into McDonald's or similar restaurant. A lot of these places will have these types of features. And these screens are basically dashboards for displaying performance measures that have been deemed important to the organization. And these stem, of course, around their drive-through. You can see on the left side of the screen, you could see the cars, the time that they've been there. There's some performance measures around the average time to serve a car within the last hour, how many cars they've served in the previous hour. And then on the right screen that you can see in there as well is, it's a little bit blurry, but what it shows is they actually display it as a leaderboard of all of the McDonald's of the similar type within the region of Calgary. And how they're doing in real time. So basically, it encourages a little bit of friendly competition. So anyway, this is a great motivator for staff, I would argue, and obviously it's been drilled into their heads that this is what we're seeking to improve and really hit the mark there, and that's how they're being evaluated. So anyway, I was waiting for our food and I checked this out. So I snapped this picture while I was waiting. And of course, I went back to the table and talked to my wife about this, because she knows that I really get jazzed about these types of things. And she said, well, that's really all fine and dandy, but I couldn't find a table that was clean. There was garbage all over the place. And the restaurant generally was very untidy, while trying to struggle with our two young kids and get them oriented for dinner. So really just highlights that, on the organization standpoint, they were hitting the mark for performance that they deemed important, but there was really a disconnect as to what was really important to my wife in that moment, which was to have, of course, a clean eating environment. And we see this in medicine, of course. Just wanted to highlight 2012 survey of top hospital leaders that was done by Merlino and Raman, as you see below. This appeared in the Harvard Business Review in 2013. So basically what they did is, very organically, they interviewed they did a survey rather of a bunch of hospital leaders across the United States, and simply asked them, what do you think matters to your patients? So you could see the top 6 things that they came back with. So new facilities, private rooms, computers, so there was a tech component to that, food on demand. So you could see there were a lot of hospitality or creature comfort type features that they came back with. Unrestricted visiting hours, of course, lots of healthcare systems have now moved away from the set visiting hour model. Of course, there's been challenges with COVID, but prior to that, there was lots of headway there. But I would argue, looking at the research and what patients indicate typically are important to them, there's not a lot of alignment here. Patients tend to strive for things around information, even really being treated with courtesy and respect from their nursing, communication with their staff. Those seem to be the things from the work that we've done in our survey research that you'll hear about in a little moment here. Those are the things that have been really important there. So there is that disconnect, I would argue. So one of the ways that we determine, what matters to patients is we simply ask patients. And I know it seems intuitive, but not all healthcare systems do that. So just to give you a glimpse into some of those activities here in Alberta, there are some large-scale surveys that are being done. The first that I'll highlight is the Canadian Patient Experiences Survey of Inpatient Care. That's the crux for the work that I did as part of my PhD. That is a large hospital-based survey that is done on a voluntary basis. It's currently administered in 7 provinces in collaboration with the Canadian Institute for Health Information. And I'll talk a little bit about that more in a little while here. Of course, the Health Quality Council of Alberta, their surveys include those in primary care, the emergency departments, as well as home care, long-term care, and designated supportive living. So they interview patients, family members, clients, and as well as those surveys as well. And there's also a very large, robust survey platform in Cancer Control Alberta. So they actually do a large amount of surveying as well across the province. Nationally, this is a few years old, this slide, but this was the Canadian Institute for Health Information who put this out, really just to get a lay of the land in terms of what patient-reported experience measures, what PREMs are being administered in the Canadian landscape. And you can see the different buckets of care in each province and territory as well. So you can see inpatient care is very widely administered, emergency department as well. And then the other sectors, perhaps a little bit less so, but still lots of presence across the country. So many healthcare systems and hospitals are using these types of tools. So now we'll just get more into the article to be discussed. So once again, it's that article right here. The research objective from that particular article was to examine the potential relationship between aspects of inpatient communication and discharge instructions with unplanned readmissions at the individual level, I'll touch on that in a moment, up to 1 year post-discharge. So just quickly, and I talk about this in the introduction to the article, readmissions to hospital are inconvenient, firstly to patients and family members. I'd be very hard pressed to find a patient or family member as they're leaving the hospital to return home saying, wow, boy, I wish I can come back to hospital in 2 weeks. This was a really fun experience. No, quite the contrary, of course. They're inconvenient. They're disruptive. You don't want to be out of your home environment. People don't technically or typically want to be in hospital. They're also inconvenient to staff and healthcare systems. They want to treat as many patients as possible. Sending folks home knowing that they're not going to come back and knowing that all of their needs are taken care of and they have the ability to mitigate things while at home is what they're striving for. Readmissions, I talk about this in the article, of course, they're costly as well. Readmissions are costly to healthcare systems. In many instances, they can be prevented. Others less so, of course. Sometimes there is a little bit of, I don't want to say luck, but sometimes things go off the rails. Unfortunately, people may just develop infections or have complications following their care. But other times there are instances where they could be preventable. And I believe in the paper, I reference an article from CIHI, the Canadian Institute for Health Information, saying that tends to range based on condition anywhere between 9 and 59% of hospital readmissions being preventable. So there is some ability there as well. And of course, from a personal standpoint, I'll be very transparent. My father, he passed away, unfortunately, at the age of 64. In the last years of his life, he was in and out of hospital quite frequently, unfortunately. He struggled with stage 2, then stage 3 lung cancer, which then, of course, metastasized to his brain and bones, being full-blown stage 4. And he had experiences throughout with acute care, so emergency departments, admissions to hospital, readmissions to hospital. And through all of those different junctures, as a family member, I really took note of some of the discontinuity in information and discontinuity in understanding of said information as well. At all the different steps of his journey, he was faced with a lot of information being thrown his way. And like many of you perhaps on the call with your own experiences, I would ask him, what did the doctor say? What did the nurses say? And of course, there would be instances where, oh, I don't remember, or I don't know, or so there were opportunities for improvements there, and I definitely took note of that. So coming back to this triple aim, looking more specifically at patient experience in that bottom left-hand corner, a lot of my research is focused on improving the patient experience, or looking at demographic clinical factors that are associated with patient experience. Who are the folks that tend to have a poor patient experience? What are the aspects of their experience that could be improved? Those types of things. But now we're starting to move the dial, and we do this in this article, where we start to look at the relationship or the potential relationship between experience and outcomes, which really comes back to the discussion that I had earlier around, the disconnect between performance measures. Is there a relationship between outcomes for a health system level and, patient experience outcomes as well? So things that are really important to the patient. And of course, we're looking at things like, is there a relationship between the patient experience and things like mortality? QOL, which is quality of life. Is there a relationship between emergency department visits, or perhaps even unplanned readmissions, which we explore in this paper? So some of the limitations of previous research in this area, where other authors have looked at patient experience versus readmissions. The two most frequent limitations, the first one is that they use hospital level analyses. So quite simply, they'll look at, the percent of patients who are readmitted within a given hospital. And then they'll also look at patient experience scores within that given hospital. And that's prone to what we call the ecological fallacy, which basically means that the data at a group level doesn't always translate to the individual level. So quite simply, if a really good real world example is a lot of times we measure income or deprivation at a postal code level. Well, of course, in an urban area, postal code can include, 100 or 200 houses. And if you look at an average income level or a deprivation or material deprivation level within that given postal code, it doesn't really reflect. You might be the high earner within that postal code, or on the flip side, you might be the low earner in that postal code. You may very well be average within your postal code, but you start to lose a lot of that disparity in the data, that distribution within the data. So it's really hard to infer that everyone is alike within that given group. And, you can make that same argument for hospital level analyses. Another thing is that they tend to measure 30-day readmissions with the HCAP survey, which is the the Hospital Consumer Assessment of Healthcare Providers and Systems Survey. For those of you not familiar, that survey was developed in the United States. We talk about it here in the paper, of course. But it actually became mandated as part of the Affordable Care Act in the United States, which of course has been modified and had provisions of it removed since that time. But basically, it was mandated that all public hospitals would administer this survey on a regular basis. So the challenge with measuring 30-day readmissions with the HCAP survey is that patients are eligible to take the survey up to 6 weeks post-discharge. And if you're only looking at 30-day readmissions, what may very well happen is someone may be readmitted to hospital, get discharged from hospital, and then they are asked to take a survey based on their first hospital visit, if you follow. So there might be some cloudiness in judgment and in terms of evaluation of the answers. So, it really ends up with a bit of a chicken and egg situation, especially so around patients who complete the survey on days 31 through 42. I know in the paper we did separate out readmissions within 30 days as well as those up to 1 year. So for those purposes, I'm really just going to focus on the results from 43 days up to 1 year in terms of the readmissions. So in terms of the methods, what we did is we took 3 years worth of survey data, and as mentioned in the paper, the HCAP survey was routinely conducted by the by Alberta Health Services. That survey has now evolved into the Canadian Patient Experiences Survey of Inpatient Care, the one that I mentioned a few slides back. And that survey is administered at 93 hospitals across the province. And in a given year, at the time, there were about 8,000 completed surveys per year. So you could see that's reflected in the 3 years of data that we looked at. So just over 24,000 surveys that we analyzed. What we did is we then linked the survey data to inpatient data also provided by Alberta Health Services via our research agreement. And we linked it using personal health number, the hospital ID number, so it's a 5-digit code identifying the hospital, as well as the date of service, so dates of discharge mostly. And the reason why we did that is we wanted to make sure that we were linking surveys up to the appropriate hospital visit, knowing that many folks, unfortunately, will have many visits in that time period. And then what we did, of course, is we looked at all-cause readmissions out to 365 days post discharge, and I'm focusing, of course, on those from 43 to 365 in today's presentation. So what we did is we looked at 5 survey questions, focusing around information exchange, involvement in care, and discharge planning, really. And those 5 survey questions, they're in the paper, but just briefly. Patient involvement in care decisions, receiving written information at discharge, understanding the purpose of taking medications once leaving the hospital, patients having an understanding of their own responsibility in managing their health. So what are the things that they could reasonably be expected to do, and perhaps what's also outside of the scope of that. And then, of course, having discussions with their healthcare team about help needed when returning home. It may require, navigating stairs as a simple example. It may require, having home care come in and perhaps do some home care visits at the time, so making sure that they have that discussion. And even so, maybe people don't need any help after returning home, but at least knowing that that conversation was had while in hospital to make sure we're not missing anything. So we also explored some other factors that have been shown to be associated with overall experience, and those are sex, age group, and education level from a demographic perspective. From a clinical perspective, whether the patient was hospitalized in the year prior, as well as the length of stay. And we divided that into, I believe it was less than 3 days, it was 3 days or less, or more than 3 days, I believe. And then we also looked at 3 other questions from the survey. On the HCAP survey, it asked participants to rate their physical and mental health on a 5-point scale. And it also asked to provide an overall rating of their care. So really high level, all things considered, what is the overall rating that you would give your care during your hospitalization, from 0 being worst to 10 being best? So we wanted to look at that as well as a factor to consider. So don't get perturbed around this equation. This is just to show that we did logistic regression. That y variable on the left side of the equation is our outcome variable. So in this case, we wanted to look at whether patients had 1 or more readmissions, unplanned readmissions to hospital following their discharge. And on the right side of that equation, just looking at all the different factors. So that included those 5 individual survey questions on their own. So we did 5 different models. And then in each of the models, what we did is we looked at the survey questions alone, but then knowing that those factors that I mentioned on the previous slide also can affect patient-reported experiences, we wanted to control for those. So basically, highlighting that when we're doing an apples to apples comparison, we're taking all of those demographic and clinical characteristics into account. Do the results from the survey questions still hold up? And we also put together some crude and adjusted odds ratios. So I'll talk about that in a moment, as well as confidence intervals. And I'll talk about that, of course, too. So in terms of the sample characteristics, that's table 3 from the paper. We could see that the sample was about 2/3 female. In terms of age group, just under half of the age group was under 50 years of age that we looked at as well. In terms of education, just over half with greater than high school level of education. And these results are pretty consistent with the standard hospital population across Alberta, as well as the population in Alberta as well. Also looking at other factors from table 3, you can see that 30% of the survey respondents that we looked at were hospitalized within the year prior to the visit that we looked at, of course. There's that length of stay, so 3 days or less. You can see about 60% tended to have a bit of a shorter stay, and about 18% had at least one readmission within the year that followed their index discharge, and that was an unplanned readmission, I should mention as well. Looking at the survey question results, this is just descriptive, just to see how folks responded to the survey questions that we looked at. This is, of course, table 4 in the paper. So firstly, patient involvement in care decisions. A very overwhelming majority said that, yes, they were involved as much as they wanted to, or they were somewhat involved. So that's a promising result. Perhaps less so for receiving written discharge information. You can see about 3 out of every 10 respondents reported not receiving any written information. Understanding the purpose of taking medications, fairly positive result there, as well as for the understanding of the patient's responsibility in managing their own health going forward. Yes, that was quite positive too. And you can see that just over about 4 out of 5 respondents reported having a discussion about any potential help needed when returning home. So overall, quite positive responses. So then we did those regression analyses. And what we're showing here is the odds of being readmitted for any cause over that period from 43 to 365 days post-discharge. The reference group is the top box. So we talk about that a little bit in the paper, but I'll clarify. What we're doing here is we're looking at the, we can see the different results for the question that we're reporting. So the odds of being readmitted to hospital, if patients said no, they were not involved in care decisions, had an odds ratio of 1.78. So basically what that means is they were 78% more likely when compared to those who said they were involved in care decisions to be readmitted to hospital, just to set that stage. And those numbers in brackets, those are the 95% confidence interval for those not familiar. So basically what that is saying is there's an element there of is this result due to chance alone? So what this result is saying is that if we were to repeat this study under the same conditions with the same population 100 times, 95 times out of those 100, we would expect that result to fall between 1.58 and 2.00, which is statistically significant. Where things are not statistically significant is if it contains the 1.00 value in that. So what we see is the crude odds ratios. So that's looking at the patient experience question alone. We're not considering all those other demographic factors. Alone, there is a very strong signal for these results. You could see that those are all statistically significant. And the odds of being rehospitalized are higher than that reference group. Perhaps more importantly from the paper is that, the blue box that I've just pulled up, what we're looking at now is that second column. That's the adjusted odds ratio. So simply put, now we're considering all of those different factors. And you can see that at the bottom of the slide. We're adjusting for sex, age group, education level, etc. Basically showing that even when we're considering those factors, you can see that those first 2 questions, patients who said they were not involved in their care decisions and patients who reported not receiving any written information at discharge, were still readmitted to hospital or had higher odds rather of being readmitted to hospital. So that's where the significant finding comes from. Once we throw those other factors into the mix, we can see those last 3 questions don't retain any statistical significance. So alone, I would argue the result alone It's not dismaying. It's probably worth a second look in terms of perhaps some other research in that area. So one of the things we also did in the paper as well is we look at the additive effect of those first two questions that remained significant. So what we wanted to do is look at the subset of patients who reported that they were not involved in care decisions, as well as not receiving written information at discharge. And we can see that there does seem to be a stronger effect there. So if we add those two effects together, even when we take those other factors into account, over here on the right-hand side, we can see that their odds of being readmitted compared to those who had received one or both of those interventions was about 54% higher. They had a 54% higher odds of being readmitted over that next year. So a little bit convoluted, but just hopefully an easier way of presenting that. So just a quick highlight of some of the study strengths, and this is mentioned in the discussion of the paper, of course, pretty standard for these types of papers. We included a robust sample from 93 Alberta hospitals, lots of variability across the province. We didn't just hone in on one model of care at one particular hospital. We're taking lots of things into account here. Once again, the administrative data holdings in Alberta are quite robust. We're capturing the entire province. Of course, Alberta Health Services is the sole provider of inpatient care across the province. We're not competing with other hospitals here, so we know that we're capturing everyone. We used a validated survey instrument with standard prompts. There are clear response options to each survey question. Simpler way of saying that is the survey is administered via a standard protocol. There's a telephone interview team that AHS employs here in Calgary who surveys weekdays and on weekends with folks. They have a standard script that they follow, so they can't really push the respondent to a given response or anything like that. There are clear response options to each survey question, and participants are asked to select the one that best suits their experience. We're looking at individual level data, of course. We're looking at each individual patient as opposed to looking at that hospital level data that I talked of earlier. And we're also looking at readmissions over a longer period of time. So perhaps getting away from that noise in the data that we see within the first 30 days. Excuse me. Also, to our knowledge, this study is a Canadian first. At the time it was for sure. I do know that there are some efforts underway. The Canadian Institute for Health Information I mentioned, they're looking into the relationship between outcomes and experience data, perhaps as a way of looking at how this data may influence care practices and policies. Some of the limitations around this data, of course, with surveys, there's always a possibility for recall bias. When folks are telephoned and asked about their healthcare experiences from, up to 6 weeks ago, there may be elements of the care that may be forgotten. People as well may be asked about elements of their care. Perhaps they weren't feeling great. They weren't in a really good headspace while they were hospitalized as well. Perhaps there was some pain medications. Perhaps they were groggy. Perhaps they had just come out of surgery and they were in a bit of a fog. So we need to take all that into account, of course. The telephone sample, some of our previous research, it may exclude some sicker patients. Simple way of saying that if I'm discharged from hospital and I'm not feeling great, I don't really expect that I would be in a position to pick up the telephone when it rings and sit on the phone for 15 minutes to do this survey. Perhaps, I don't want to talk to folks. And some of our previous research does in fact show that. The survey is cross-sectional in nature, so it's taken at one time point. Based on that, it's really hard to infer causation. And what I mean by that is in this paper, we are very, very careful. The only thing that we're able to say based on our results is there's an association between those patient experience measures and unplanned readmissions. We can't go and say that there's a causation attributed. So the results on the survey are causing those readmissions, or because of how people responded to the survey, that's impacting readmissions. All we can say that there's an association there. And also, surveys are administered at different points of the illness trajectory. For those of you living with chronic conditions, You can appreciate the fact that when you're surveyed, you might be having a really, really good day. You might be managing your care quite well. You may have had, 3, 4, 5, etc. years to learn what works for you, and really get that under control for yourself, and really be at a good place with that. Your responses to the survey may be grossly different if you're newly diagnosed, and perhaps you haven't really found a treatment regimen or things that work for your particular condition. So there might be some differences in responses there. So just under discussion here, so we did show that patient involvement in their care and receiving written information at discharge were associated with unplanned readmissions up to that 1-year time point. I also would argue that the study is a really good example of how patient-reported measures can be linked to administrative data to address questions related to that Institute for Healthcare Improvement triple aim. And I'd also argue that this is a really, really expanding area of research. This is a really exciting area of research where we start to integrate patient-reported hospital experiences with other health system measures. I'd argue that it's due time to do lots of these analyses and learning a lot more from patients and their families and the valuable insights that they can bring to the table. Lastly, just before we get to the discussion, I'd like to acknowledge the patients, firstly, who graciously completed the survey. It's no small feat to respond to the survey, and really appreciative of the time they took and the commitment they have to improving care for future patients. I'd also like to thank the folks at Alberta Health Services for providing this data through our sharing agreement and really being transparent and helpful with that. I'd also like to thank the Canadian Institute for Health Research, who helped fund this research, as well as the Alberta AbSPORU Support Unit for their support. And lastly, I'd like to thank my co-supervisors in my PhD work, who are also co-authors on this paper, and that would be Dr. Maria Santana, who's here today, as well as Dr. Huda Kwan, both out of the Department of Community Health Sciences. And at this point, I'll just throw out my contact info right here. And once again, really thank you for joining us today and look forward to our discussions. So I'm just going to go ahead and stop sharing so I can see everyone's faces, if that's all right.